the affinity for hemoglobin, for oxygen to hemoglobin in various physiologic circumstances, pH, temperature, altitude, things like that. We're not really going to dig deep into the biochemistry of it. So if you have prefaced the slides or like previewed the slides, don't worry. This is about the bottom line. Today we're just doing anatomy like we usually do in the first day, and then we will. I won't see you again until I think next Tuesday. I know your schedule has me on Monday, but I switched with micro, so I'll see you actually on Tuesday. All right, and then we'll finish it up. So let's get started. Easy stuff. Again, we talk about this just so that you understand your consultants when it's time to make consultations. Who do you send these patients to? So otorhinolaryngology, E&T is an easier way to say that, right? So the head holes, okay, that's your people for the head holes, all right? And then pulmonology for lungs, all right? Otorhinolaryngology is a surgical subspecialty though. So they are a crossover. They're one of the, I mean not the only, but they're one of the unique crossovers that crosses over between medicine and surgical subspecialty because they do, tracheotomies, they do tracheectomies, they do your, A&P tubes. Your kids had tubes in their ears. That's a surgical subspecialty. They also cross over into medicine. And then pulmonology is our medicine guys. And if you need surgery in this region, then you're talking to a cardiothoracic surgeon. All right, so those are your consultants. What basic information? We've already talked about a lot of this stuff already, and most of this is a lot of crossover between our circulatory and our cardiology from the very, very beginning. Okay, so what are we doing? What's the goal of the pulmonary system? To inhale oxygen and to exhale and expel waste gas, specifically CO2. All right, we all know that, and that's on the slide. So there you go. All right. So if either of these two systems shut down, either of these systems work, we've already talked about what's the real movement of oxygen and carbon dioxide. How does it move from the red cell into the tissue? Simple diffusion, right? Simple diffusion, partial pressure. We're going to talk a lot now about that layer of partial pressure. And we've already really discussed it. Where is the partial pressure of oxygen higher in the arterial blood, and it's lower in the tissue? So we're perfusing, where oxygen is moving by simple diffusion into the tissues off of the hemoglobin, and then vice versa for carbon dioxide back into the blood to be expelled and removed, correct? Easy, all right? Respiratory system does all these things, and this is the physiology that we're going to talk about today. The anatomy. A lot of the air filtration stuff, when you wake up, how many people here when they wake up, they're stuffed up? They have a lot of extra mucus, right? Those cilia and those mucus cells in your body actually work overtime during the regenerative portion of sleep. So that's why you wake up all stuffy and gross in the morning, all right? So that's big portion of it, is to filter what we breathe in, to humidify and warm it, to get the particulate matter out of there, and then to deliver nice clean oxygen into the lungs, all right? This one right here, I just added an informational slide next. Has anybody heard of the difference between sensate and insensate water losses? Anyone familiar with that term, all right? So sensate water losses, or sensible water losses, are the ones that we can measure, ones that are overt. Like if you have diarrhea, if you're throwing up, what you expel through urine, or the water that you lose in feces, are sensible, measurable amounts. Insensible water loss are things like the respiratory system and perspiration. Now you can directly measure perspiration, but you really can't measure how much water you're expelling through water vapor in your respiratory system. And this isn't important. I just put it on here as a gee whiz for my slides. But you see how much water you can theoretically lose on a given day. Half a liter of water, right? So why is that important? When would that be important? Imagine if you have that's a great example, whoever said that, a burn patient. Somebody who you're really closely measuring their ins and outs of their water, of their fluid status. If you don't take into account these insensible water losses, then you're going to underestimate their fluid needs, and the patient's going to be dehydrated, hypovolemic. Does that make sense? So it is actually quite a bit of water. I mean, half a liter is quite a bit of water, right? Some of us don't need that much in a day because they're too busy drinking Monsters and other shit like that. You know what I mean? So anyway, enough of that. Well, I mean, I do it too. I'm just saying. So you don't know what's in this cup. Respiratory system anatomy. So, nose, pharynx, larynx, trachea, bronchi, lungs, as we're going to be talking about. I wish it was that simple, but unfortunately it's not. Okay? And if you, there's a picture of those things in case you forgot where they were. Okay? Your nose is typically your highest head hole, down to your mouth, and then your lungs. Okay? If they were outside your body, this is what they would look like, and we know a lot of this anatomy already. Okay. Everybody remember the branches of the aortic arch? You remember that they exist. All right. Remember they were in alphabetical order. That's right, BCS. See, you guys are learning something. All right. So we categorize the actual anatomy in two different ways: structural and functional. Okay. Even the structural anatomy has function, but like what this really specifically refers to as most of the upper airway passages down into the lungs themselves are conducting zone, meaning they're bringing the air to the portions of the bronchioles, to the portion of the lung parenchyma that actually then creates respiration, oxygen exchange and carbon dioxide exchange, okay? So if you are looking at this, lower respiratory versus upper respiratory system, how many people, just out of show of hands, out of curiosity, how many people here have been diagnosed with an upper respiratory infection when your lungs were congested? Probably because it's the easiest go-to diagnosis. Are you sick? You've got a URI. Well, no, I've got shit in my lungs, so I don't have an upper respiratory infection. Clinically, it makes a difference. You see what I'm saying? If you have technically, the lowest portion of the upper respiratory system is the larynx, the hypopharynx, if you want to call it that. Anything below that is a lower respiratory infection, and it just means when I was teaching the clinical classes, I would really harp on precision diagnostics, like what does this patient actually have? You know what I mean? Sometimes, just to talk about something we've already talked about, a patient just has diarrhea. You know, you think that they have gastroenteritis, but you can just diagnose a patient with diarrhea because that's what they have. All right. With this, if they have nasal congestion, then they can have an upper respiratory infection. If they have a productive cough, then they probably don't have an upper respiratory infection. All right? Sometimes it's just a lazy ICD-10 code that you just put in because whatever, you have a cold and you just want to see your next 75 patients. You know what I mean? Sorry, another soapbox in mind. Okay. So functional, conducting zone versus respiratory zone. And here's an easy way to start understanding where the respiratory zone begins. At the respiratory bronchioles. Fairly convenient, right? What does that really mean? It means that there's no gas exchange happening in the nose, mouth, pharynx, or even the upper part of the trachea. The gas exchange isn't really starting until we get down into the respiratory bronchioles. That's why the conducting zone brings it to the respiratory zone, okay? Simple concept. When we get to teasing down into the anatomy of the bronchi, the bronchioles, and so on and so forth, it'll make a little bit more sense. But it's an easy way to understand the delineation point, just like the ligament of Treitz, right? Okay. The what? Anyway. So, but again, the terminal bronchial, I mean, it really becomes like a very easy way to remember. The terminal bronchial terminates the conducting zone, the respiratory bronchial initiates the respiratory zone. Again, simple memory tricks are simple. All right, enough about that. The nose. First part has a lot to do with our respiration, okay? Do you ever call somebody a mouth breather? Infantry dudes, right, mostly. Like, yeah. Hey, take it easy. You know who you are. All right, so external aspect. The nose, the bony portion of the nose, some of us have more nose than others. And then bony portion of the nose, and then the septal cartilage, right? Cartilage is the friable part. Now we're going to talk about, I talked to you guys about cauliflower ear, right? So you can have something similar in the nose, and I'll talk to you when I get to the quadrangular cartilage and how that goes, but it's called saddle nose deformity, all right? And the external nair, I love this one. External nairs are the openings of the nose on the face. That is correct. Okay? If you think, I'm not going to put that on the test, I'm sorry, y'all. What are the openings of the nose and the face? But, all right. So cartilage here, cartilage, and then our nasal bones right here. Very small bones, hard to reset. Can cause a disruption if they are punched, for example, right? You can get what's called a deviated nasal septum. But anterior, the actual nasal cavity, it's a huge space. You guys remember seeing that sagittal section of the head when we had the digestive lab, when we were supposed to, looking at the tongue and whatnot? You're able to see the nasal concha, which are the turbinates, actually huge nasal cavity. And it's important to you too, when you look at the nasal cavity. Just here's a hint for you when you get to your A&P class next semester, all right? When you're giving somebody a nasal spray, people want to spray up. That's where your brain is, right? Your nasal cavity is this way. So tell your patients to shoot their like Flonase or nasal spray, whatever you give them, Afrin, back towards the top of their ear. That actually takes it into the nasal cavity, all right? And also tell them not to after they do it, because then they're just sucking it right into the stomach, all right? So nice, deep, slow breath, and it'll actually do what it's supposed to do where it's supposed to do it. If you shoot it up into your brain, it's just gonna fall back down, okay? You guys don't look interested? Too bad. Again, I have the microphone. All right, so. Posteriorly, what is the back portion? The back portion is the nasal choana. That's how you say this word in case anybody was wondering. Choana, okay? Basically two big holes posterior that enter in the nasopharynx, all right? How the air moves through, where an NG2 goes through, those kind of things, okay? Sinuses, so you have maxillary, frontal sinuses, sphenoidal, and ethmoidal, okay? I'm going to talk about sinuses and sinusitis, particularly sinus development in children, just very briefly. All right, you got to be careful with the diagnosis of sinusitis in a child, because depending on the age of the child, they might not have the sinuses that you think that they do. All right, they progress and grow as patients age. All right, but maxillary sinus in your maxillary bone, frontal bone, and then your ethmoidal and sphenoidal sinuses, usually less of a problem unless somebody really has chronic sinusitis, right? But usually when people think of sinusitis, they're thinking of their maxillary bone or their maxillary bone and their frontal bone, right? You guys have sinusitis before? You ever feel like when you bend over, like your face is going to come off? That's sinusitis, right? So, these are the choana right here. Just your posterior openings, right? Things that are opening into the nasopharynx. And this is what you were able to see if you saw that sagittal section of the head. So these three ridges, all right, are concha. You'll see them depending on where you're looking. Concha, but what they also refer to as turbinates. Has everybody heard of nasal turbinates before? Anybody looked in the nose with a nasoscope before? Have you guys done that already in clin steel? So what you're seeing, that's what you're seeing, but from an anterior, of course, anterior view. Those ridges, all right, they help move the air around, moisten it, warm it, make it turbulent so that it's not irritating to the nasopharynx when you breathe it in. Okay. Oh, let me go back one other thing. Where is it? Oh, it's not this one. I'll go to the next one. All right. So anyway, ethmoid forms the roof. Palatine bones. So we talked about the hard palate. The palatine bones form the floor of the nasal cavity. And then the lateral walls are the ethmoid and various other ones, all right? But the roof of the ethmoid bone is this guy right here, all right? It says the superior and the middle nasoconcha. So again, the turbinates are formed by the ethmoid bone. The superior and the middle are formed by the ethmoid bone. And that's these ridges right here that you can kind of see here. Here. And again, when you're looking straight in, those are the nasal turbinates that you see. Too fast? Are we good? Disinterested? Anyone? Does it help if I keep doing these segues? It makes it longer. Like when somebody's giving a speech and they're like, I'm not going to make this speech very long. I know you guys got places to be, and they spend 15 minutes talking about how they're not going to make the speech long. Like what I'm doing right now. Isn't that annoying? All right. So, the vestibule right here, this is the anterior portion of the nose, and the nasal septum, again, it's not just bone. There's a bony septum and there's a cartilaginous septum. The cartilaginous septum is where we have the problem if there's trauma to that area. Do you remember what I said about why cauliflower ear forms? The vascularness, like how is cartilage fed? It's fed by direct contact with the blood vessels of the skin that is in contact with. So if you get a hematoma that creates space between the skin and the cartilage, then you lose that cartilage tissue, you lose oxygenation through ischemia and then ultimately sort of necrosis of that cartilage. The same thing can happen in this cartilaginous piece of the nose here, the quadrangular cartilage, right? That's the real nasal cartilage, the part of the nose that you can move, that's that. So if you get punched in the nose, whatever kind of trauma, sports, whatever, right? Then you get a hematoma that forms between the skin of that cartilage, the mucosal skin inside your nose, and that cartilage itself. Then if you don't evacuate that, the cartilage isn't fed, no oxygen, it dies, and you get what's called a saddle nose deformity, like a dip, a divot. It can be pretty pronounced and severe in your patients. So if you're ever looking at facial or nasal trauma, it's imperative that you look in the nose not just for other things, but for what's called a nasal hematoma, septal hematoma. And if you see that, it needs to be evacuated. And it's something that you can do in the emergency room. It's also something you can just refer to ER if you don't feel like it, because you have to put something in there like a nasal pledge, or you have to sew a pledget across the nose, across the nasal septum so that it holds that space, right? Just like I talked about, if you evacuate an auricular hematoma, you have to you basically sew like a dental pledget across on both sides to hold the skin onto the cartilage, okay? So anyway, long story short, septal hematoma can create a very bad cosmetic outcome, all right? So make sure you check for it. So bone, and then quadrangular cartilage, just because it's got 4 sides, all right? Deviated nasal septum is something else, right? Deviated nasal septum means one side to the other. You can have it as a traumatic deviated nasal septum, or it can be a congenital deviated nasal septum. So basically the patient has an uneven nasal cavity, right? The septum goes more to one side than the other. Oftentimes it is traumatic, all right? And it usually is between where the vomer and the quadrangular cartilage. So usually in this area somewhere, there's damage, and so the septum kind of pushes to one side or the other, and then what does that create in your patient? This chronic nasal obstruction, right? One side is more difficult to breathe in, so that patient is sounds like they're congested, they chronically have difficulty breathing out of that one side. So they have worse outcomes if they have an upper respiratory infection, and they can only breathe out of one side anyway, okay? And that, you can do a septal rhinoplasty and refer them on to A&P. There's nothing really we can do for that. I mean, the closest we can come is to give them some Flonase just to open up the mucosa on that side, but really what they need is a surgical repair to put it back into the nose, okay? Sinus cavities, now you'll see this again when you talk about when you get to pediatrics, but oftentimes, as far as lazy diagnoses go, you'll have providers, practitioners, who will diagnose kids with sinusitis, and depending on the age of the child, they may not even have a functional sinus that can contribute to that pathology, all right? So when you're born, you have all of the sinus cavities. Like it says here, what it refers to is when it's radiographically visible. So if you were to take a frontal or a sinus x-ray, you could actually see air in the cavity, all right? So as they get older, the patients develop more and more sinuses. But again, like the frontal sinuses, where a lot of people will diagnose sinusitis, right here, frontal, maxillary. So everybody has their maxillary sinus, but they continue to grow. Frontal sinuses aren't even really present in a younger child until they get to be about, 5, 6. So if you're diagnosing a patient with frontal sinusitis, when they're younger than that, they really have something else going on, all right? But what are the signs, like why do we even have the sinus cavities? Filtration, all right, they actually have a significant function in phonation, speech, talking, resonation, so like resonant chambers, all right, structure to the face, yes, okay. And so this is just a little of the maxillary sinus. So even in, you know, you have like a little 2-year-old kid, they do have the ability to get sinusitis, you know, sinus congestion. But really what we're talking, you know, when it really presents as frank sinusitis, like what somebody in this room would have, it's not until probably teenage years that they can really experience something like that. And here's all your other sinuses. So again, the frontal sinuses in the frontal bone, these are the most pathologically significant ones, I guess you could say. Ones that cause the most trouble for patients. And there, what's the real problem? What's the problem with sinusitis? What have I said is bad? Static fluid, right? Static fluid. Here's a quick setup for sinusitis. You do have an upper respiratory infection like a cold, right? You get blockage of eustachian tubes, right? Your ET tubes. That creates a setup for static fluid. It sort of backs up into your sinuses. Now you have fluid in your sinuses. It sits there. What happens? Shit grows in it. And then you end up with sinusitis, all right? And I'm not going to get into the clinical clues of sinusitis right now. Just understand that true sinusitis has specific things you need to look for versus just like an upper respiratory infection or a cold, or even blocked sinuses, right? What we're looking for is like a fever, tooth pain, so on and so forth, okay? Any questions so far? Are you okay? Is everybody okay? All right. Yes. All right. Stick. We're going to be there. It's only like 50 more slides. You guys will be out of here before you know. The slides are easy. We're talking about nodes. Come on. So wait. You guys have done heart, GI, and Andrew, you can do nose with me. We can get there. So, air comes in. We have mucosal cells lining the nose. They dry out. What do you get? Anybody? Boogers. Yeah. All right. What are that's just mucus? That's normally produced mucus that has caught a bunch of dust and particulate matter and dead skin, and it accumulates in the nose, and you blow it out. That's what boogers are. All right. All right. Anyway. So, what do the turbinates do? So the concha bones, right? The nasal concha, I told you the other word would be turbinates. This is what you'll see more clinically used, right? It's turbinates. The bones, the passages, the things that stick out that you can physically appreciate, those are the turbinates, and the space between the turbinates are the meatuses. It's just air, it's just an air passage that creates turbulence, moisture, cilia, and mucus in order to whisk away any particulate matter before it enters the nasopharynx and then down to the lungs, okay? So, all of this, goblet cells, remember those? Goblets of mucus, right? Still the mucus producing cells. And it's all they're doing is lining that to keep it moist, to keep it warm, and to catch anything that doesn't belong in the lungs before it gets there. So if you're looking at this, like straight on, and if you're looking in that nasoscope, what you see sticking out are the concha or the turbinates, and then that space between are the meatus. All right, so empty space is the meatus, the actual physical structure is the turbinate. And this is what you're all able to see, again, on that section. And then this is what I was looking for the other way. See the opening of the eustachian tube. I know we haven't got to that yet, but again, the reason why you get eustachian tube dysfunction, why you get a stuffy ear when you get a stuffy nose, is because you get blockage of that eustachian tube, so you can't clear, right? So the fluid just sort of builds up in there. That's also a setup for an ear infection. That's how kids get ear infections a lot, because they can't drain down to here like it's supposed to. So again, looking through the nasoscope, you guys have seen this view. We've got turbinate, and we've got meatus, right? Inferior is what you're looking at most. There was a provider when I was on rotation, and when I was doing my E&T rotation, that referred every patient that she saw to the doc because she thought that that was a nasal polyp. And so I got to listen to the doc teach her anatomy on the phone, which was slightly hilarious and embarrassing for her probably, but I thought it was funny. Anyway, so don't do that, okay? So air goes over the turbinates, it warms it because you have a very capillary rich mucosa there, all right? You guys, the most frequent cause of anterior nosebleed is what's called Kisselbach's plexus. It's a plexus of capillaries very, very near the surface in the anterior portion of your nose. So if your kids get nose, it's because they're picking it probably and getting that, irritating and opening that. Or if you have chronically dry nasal mucosa, then that can become friable and it can bleed. So in very, very dry air, patients who are prone to it can get nosebleeds, anterior nosebleed, Kisselbach's plexus. Easiest thing to do for that, just put a little Vaseline in your nose and keep it moist, all right? There's nasal cilia, again, just the beats of those cilia trying to whisk the mucosa, the mucus and the bad stuff out, right? That is really the reason why we create snot booger, okay? Any questions there? No? All right. So pharynx, we've already talked about this, respiratory and digestive functions, depending on the part, okay? So we have deglutition, right? We have the tonsils and the pharynx, which we'll talk about in their pathology as it relates to the respiratory system. Sound resonations we'll talk about as air moves through the vocal cords, how we create sound briefly. And dividing the pharynx into regions we've talked about in this part. We're going to talk more about the nasopharynx. Okay. Only respiratory function, no digestive function, right? Because food's not supposed to be going in that direction. So what closes off the nasopharynx when you swallow? The soft palate uvula, right? Right? Exactly. Okay. We have the pharyngeal tonsils, the adenoids up there. We talked about where they are and if they get enlarged, why they can cause problems. We'll see that again here in a little bit. And then our eustachian tubes, again, for pressure equalization, auditory tubes drain into the nasopharynx and their secretions just go down into the stomach, okay? So if you see this, here's our adenoids right here. And again, they become a problem. If they're swollen, they can impede upon the eustachian tube opening and just the nasopharynx itself, the opening of the nasopharynx itself. So that's why if patients have chronic allergies, chronic tonsillitis, oftentimes they'll have the adenoids taken out as well in order to help with breathing, right, and reduce their symptoms overall. If you look at this, the eustachian tube here, in kids, right, the reason why kids get more frequent ear infections than adults do is because their eustachian tubes are a lot flatter and shorter. All right, so the drainage, gravity's not their friend in this case. They have a lot more flat. So stuff gets caught up in there more, and you get more set up for ear infections. That's why kids, you'll see ear infections in your peds rotation all the time, very infrequently in your adults. All right, because when we grow up, they become a lot more vertical, or at least diagonal, if you will. And so the drainage is more facilitated that way. But again, when you have drain blockage here, whether it be your adenoids or whatever, fluid just heads in this direction and accumulates here in your middle ear. And then that's why you see this bulging tympanic membrane. Is all the signs and symptoms of ear infection. Right? Anybody ever had an ear infection or the worst? Okay. Oral pharynx. discussed that in the digestive block, primarily digestive function, although of course you can breathe out of your mouth, right? Not even listening. Mouth breather. So tonsils we have here, palatine lingual tonsils, right? Most of the tonsils, that we refer to as tonsillitis, when we look into the patients, that's the palatine tonsils. Okay? The laryngopharynx / hypopharynx, interchangeable names for the same region, right? In this portion we have the larynx, right? This is the portion where at the beginning, this is where it really transitions into both the esophagus posterior and the trachea anterior, all right? So this one has both types of functions just based on where it is. So if you look at the laryngopharynx, it's basically from the epiglottis sort of to the end of the end of the upper respiratory system. That's the end of the upper respiratory system. All right. So pharyngitis, sore throat, this is pretty ugly looking. You see these bulging tonsils here, right? What's this stuff here? Yeah, it looks like exudate, yeah. Gross. Patients. Then most of our sore throat, most of our pharyngitis is going to be viral, all right? Not everybody who has a sore throat, or even who has tonsillitis, has strep throat, all right? Back to precision in your diagnostics, right? If you have a rapid strep test, and you get that, and you have positive streptococcal pharyngitis, then you can diagnose that patient with strep throat. If you don't, then what's their presumptive diagnosis? Tonsillitis, right? Or pharyngitis. Because you don't know. You can't diagnose somebody with strep throat if they don't have strep. See what I mean? Precision in diagnostics. Okay? ICD-10 codes. It'll make more sense later. All right. Here, I don't know, I'm going to have to switch to another color, obviously, but here, you've got little, and it gets worse depending on your patients, with these little bumps. It's called cobblestoning. That's not really a bad example, but cobblestoning is kind of a hallmark of postnasal drip. And what that represents is just irritation and inflammation in the back of your throat. So a lot of times when you have patients with postnasal drip because they have some kind of like a cold or an upper respiratory infection, what they'll complain of is a sore throat, a really bad sore throat in the morning, first thing in the morning, and a cough at night, and then the symptoms will sort of resolve during the day. And the reason is just simply gravity. Like when they're laying down, all that snot is just running down the back of their throat, irritating the back of their throat, stimulating the cough reflex. When they wake up, all of that inflammation hurts. Then they stand up and the snot just kind of settles in a little bit more. They're not swallowing so much of it, and so their cough resolves a little bit. Their sore throat gets a little bit better. So that's sort of a hallmark of just something as simple as postnasal drip. Okay? Exudate, streaking exudate on this one, right? Streaks, literal. And exudate is just this gross purulent material, right? A lot of dead white cells, dead bacteria, okay? And then petechia are these little dots, right? Little small dots. Capillary bleeding. All right. Questions? You guys are hanging in there real well. We're almost done. I'm gonna stop screwing around and finish this up. All right. So the larynx itself, even though this is this looks like a large area, it's really a fairly small portion. Oh, excuse me. I'm sorry. A fairly small portion of the laryngopharynx itself. I'll switch to I gotta get a different color. Not gonna work. Here we go. So it really is kind of made the superior portion of the epiglottis and then right to the remiglottis. Anybody know what the remiglottis is? Remiglottis or the glottis? Anybody know? It's the hole. It's the trachea hole. Okay. Space between the vocal cords. And it's on the slides. I just want to see if anybody knew. Anyway. So the larynx, very short portion. Voice box, right? Familiar with that? Laryngitis, what is that? What do people associate with laryngitis? Losing your voice, right? It's the voice box. The area of voice production, phonation. Okay? So, closed, and what closes it? The epiglottis, right? Yeah. Uvula swings up when we swallow, epiglottis swings down, so that the food goes into the food tube but not the air tube. Right? Right. Okay. So, vocal cords here, the true cords, right? The thing that you can see that everybody identifies as your vocal cords. And these are going to be false cords that we'll talk about in just a minute. And the remiglottis, or the glottis is the hole. Okay, the air hole. Cartilage, okay? Probably get into some portions here that people are fairly familiar with when we talk about cartilage in the throat, right? Thyroid cartilage, that creates our Adam's apple. That's the most common one that you can see. The epiglottis is technically a piece of cartilage in the back that is covered by tissue. And then the cricoid cartilage itself. All right. And then these are small pieces that basically are used for moving the vocal cords in and out to create sound. But if you look at what is your Adam's apple, this thyroid angle, it's not important that you know the thyroid angle. This isn't the important part. The part that is just clinically important, just as a anatomic landmark, you know, the Adam's apple, the prominence of the Adam's apple is because the thyroid cartilage in male is has a narrower angle, so it comes to a higher point. The point is actually called the laryngeal prominence on the thyroid cartilage, right? Why? I don't know, because it has to be confusing. But that's your Adam's apple that you can see. Okay? That really gives us structure, you know, creates a great deal of structure there in the larynx and the voice box for the trachea. Because the trachea itself is a collapsible tube if it weren't for these cartilage rings that we have. Alright? So, Adam's apple, thyroid cartilage, the big, huge thing that you can feel is thyroid cartilage. Right? Right underneath that, we're going to talk about cricothyroid membrane and the cricoid cartilage. Okay? And looking at this is a good anterior posterior picture. Look at the difference of the cricoid cartilage here. It is a true ring. See, it goes around. Anterior and posterior cartilage. Versus underneath it, you see the tracheal rings that are open posteriorly. Okay, so those are like C's versus the cricoid cartilage, which is a true ring around. Okay. You remember talking about there being this little pyramid lobe of the thyroid that impedes potentially over the cricothyroid membrane? Remember from endo? Yeah. So again, is it important if you're doing an emergency cricothyroidotomy? No. You'll be just fine without that little piece. Okay. You need to breathe more than you need thyroid hormone. And like on the necessity chart, air is higher. Okay, so the epiglottis we've talked about ad nauseum at this point. You understand what it is. Okay, really is just a fold of cartilage that help prevent any kind of food, debris, anything that's not supposed to be in the lungs from getting in there. Okay. Protects the trachea when swallowed. Also, where part of the cough reflex is stimulated, that way if something starts to make its way down past the epiglottis, help expel that stuff, right, to get it out. We don't want anything that doesn't belong there. So when you swallow your food wrong, right, makes it a little bit past the epiglottis, stimulates the cough reflex so it goes out, right, because that piece of chicken doesn't belong in your lungs, it belongs in your stomach, okay? So, there is a view of the epiglottis here, and epiglottis here. It folds back, covers this, so food doesn't go in there. Alright? And again, what is the hole called? The glottis, there you go. The glottis, or the rim glottis, for you Latin folks. Okay? Cricoid cartilage, true ring, as we discussed, the only one that goes all the way around circumferentially. The rest of the tracheal rings are like C's, so they don't. Okay? Cricoid cartilage is essentially your landmark for your cricothyroidotomy. So if you all feel under your tracheal cartilage and above your cricoid cartilage, you feel this little divot, a little porcelain right there. It doesn't feel good. Right? That's your cricothyroid membrane, and that is your landmark for a cric. Okay? Most commonly. So, cricoid cartilage, again, going all the way around, thyroid cartilage, and your cricothyroid membrane is going to be. Okay. Cricothyroid membrane right here. There's a good anatomical look at it right here, encased in these arrows. Okay. Seemingly small, but big enough for a tube to go in. All right. Temporary tube with leak. And again, the easiest way, the easiest way is just, I always start at the Adam's apple and just go down until you feel that little divot. Okay? And I know you don't have this slide. The only reason I added it is just, again, to show you, just to reinforce the concept that the cricoid cartilage goes all the way around and the tracheal cartilages, do not. Okay? You guys good? Am I going too fast tonight? Trying to hit the sweet spot and get you guys out of here and rush it. So, all right. So, this seems like, I never really harp on histology. It seems like a minor point, but why is this important? Why is this part important? With inferior to the vocal cords, where we have cilia, goblet cells, especially. Why is that important? Yeah, the mucus production in the cilia to beat and get stuff out if you need to, like protection. It's got a protective function. Above the vocal cords, it still has sort of, above the, at least the epiglottis, you have oral secretions, right? When you get to the bottom part, inferior distal to the vocal cords, now it's respiratory tissue. Like we're really protecting the respiratory system, right? We don't have any of those oral secretions. So it creates the mucus in order to be protective of where the airway passageways. Does that make sense to everybody? Okay. We're almost done. So vocal cords, we have the vocal folds here, what we see as the vocal cords if you were to look on a laryngoscope, okay? And then you have here the vestibular folds, which are the false vocal cords here, all right? So the true cords are what we look at, what we see, right, as the vocal cords, and the false cords are the tissue to the left and right, to the outside, all right? And then again, the interior is the rim glottis. So this is, again, if you see the rim glottis, it's just the fancier Latin name for the glottis. And again, it's just the opening, tracheal opening, okay? So, true cords here, false cords laterally. Simple, it really is, okay? This right here is another leftover from my friend who was a heavy metal fan along with her husband. And so if you fancy some weird heavy metal music, you can YouTube like singing with your false vocal cords, and it makes that weird deep like screaming barking sound. So it's pretty impressive. I've taken it out because we don't have time for it, but we do, but I just don't want to play it. So, but it's pretty interesting, all right? So they have more structural function, but they can be used for phonation again in that weird way. It doesn't sound like it's guttural, is the best way I can describe it, okay? And then obviously the true chords, as they move, as they stretch or they relax, create different sounds for phonation. This is the main part here. I know it seems like there's an inordinate amount of time on voice production, but truthfully, narrowing the rhythmic narrowing the tracheal opening, and stretching or relaxing the chords, that creates voice sound. I'm going to make it very easy, right? If the chords are tight, right, like a tighter string, it creates a higher pitch. If they're more relaxed, like a looser string on a string instrument, it creates a deeper sound, a lower pitch, all right? So, you see what I'm saying? Don't focus too much time on the previous slide about all that stuff. Really, we're just looking at how do we create voice production. It really, honestly for us, this is not super clinically relevant, except there's one. Does anybody know of a vocal cord disorder that can be mistaken for asthma or give breathing problems? Anybody know? It's called vocal cord dysfunction. And so we can have a paradoxical opening and closing of the vocal cords, and it happens a lot in children. And oftentimes, the most common misdiagnosis is asthma, because it seems like asthma, because it causes a cough, causes difficulty breathing, particularly with exertion. All of that sounds like asthma. So vocal cord dysfunction is something to keep in your brain once you learn about it later as a potential differential diagnosis. And it really is just a paradoxical motion, like when they should be open, they're closing, and vice versa. So that causes that breathing difficulty. Clinically, that's the most important thing. Now really, who are we going to send somebody with true vocal cord problem to in general? Huh? E&T, speech pathology, right? So there's not a whole lot we can do in our primary care realm for vocal cord problems. All right? Recognize it, keep it in your differential diagnosis, because there's an old saying, if you never look for it, you never find it, right? So keep things in your differential diagnosis, even the zebras, okay? Whispering, so when you whisper, depending on how, I feel like I'm a loud whisperer, and other people in the back of the room, when Nolan is especially a loud whisperer, right? So they're trying to take their test, and he's whispering like this, like you're not really whispering. You're whisper shouting, anyway. So your cords aren't supposed to move when you whisper, right? Unless you're bad at whispering, and then they probably move a little bit. As you can tell, I'm almost done for the day. My material is getting thin. All right, so, and then voice production, again, seems like an inordinate amount of slides, don't worry about it. You just understand, coordination, like this is what speech pathology does. Coordination of the muscles of the mouth, coordination of the tongue in order to create proper consonant and vowel sounds. Using the vocal cords, vocal cord exercises that they can do in order to help your patients. If they have a speech delay or speech impediment or what have you, they really do fantastic, amazing things to bring them along, right? So us, again, you actually hit it right in the head. Us as primary care, what do we do about things like this? We recognize the problem, recognize potential anatomy dysfunction, and we send it on, okay? That's enough to be said about both voice production. So you have tight vocal cords, high pitch, looser vocal cords, low pitch. Kind of like I said, a string instrument, okay? Seems like a lot for 15 minutes, but I think you guys did great. Yeah. This will be the end, right? And the reason why, I know it sounds like this is a chintzy question, it's important anatomically, right? Delineation. So the larynx is part of the laryngopharynx, so the end of the laryngopharynx is technically the end of the upper airway, or the upper respiratory tract, okay? So this is another picture you don't have, but again, the larynx is sort of in the middle of the laryngopharynx, and then just below that is what we consider the end of the upper respiratory tract, okay? Which one? A opens in the nasopharynx again. So should drain down. We have the problems with potential sinusitis, sinus congestion, We have the potential of eustachian tooth dysfunction if we have adenoid inflammation. So any kind of nasal congestion can lead into ear problems, can lead into full congestion, right? So again, it's anatomically not very gee whiz, right? You guys, it's like, yeah, okay, great. But clinically, it makes sense, and it helps you to know how you can sort of take backward steps of what started this patient's ear infection, what started this patient's sinusitis, right? So if you can pinpoint, well, they had an upper respiratory infection, or they had allergy symptoms a week ago, now they're here with severe frontal sinus pain and a fever and tooth pain, well, you can sort of put two and two together how it happened, and you can eventually not just treat the current problem, but you can treat the genesis of the problem, right? If this patient has chronic allergies or what have you, you can treat that to prevent this from happening again. Does that make sense? So that's why anatomy is useful. Anyway, I don't have anything else for today. Thank you guys and good luck tomorrow. Any questions? All right.